Right, folks. Well, this is a virtual experience, and I'm very grateful to my colleagues, Claire Gerada and David Wrigley, who've made this happen. And my brief today was to talk about protecting our colleagues, BAME and IMGs. And I'm going to take you through a series of issues that I want you to think about. So not many answers, but several questions I have now. So these are my declarations of interests. And of course, ethnicity, as you're aware, is a complex construct influenced by genetics, culture, race, and with no homogeneity. I think those are the basic principles of my talk. It's a crude tool to study population differences, and international medical graduates are those with their primary medical qualifications from non-EU, UK countries. So these are the contents of my talk. I'll take you through ethnic disparities. Is the virus racist? Is the NHS institutionally racist? Racism in medicine, and also I'm going to give you my 5 top tips for this issue. Now these are our NHS heroes who've paid the ultimate sacrifice. Our hearts go out to them and their families and friends. And the question I ask is, and so many have, why so many BAME? Now, ethnic disparities, I'm going to tell you a little bit about ethnic disparities within the NHS and then talk about medicine as a whole. So ethnic disparities have influenced treatment outcomes in patients with tuberculosis, cancer, schizophrenia. And during the 2009-2010 influenza H1N1 pandemic, it was already known that non-whites are overrepresented in mortality rates. And in China and Europe, Italy, Spain, that sort of thing, there were already data coming out that the ethnicity does matter in terms of mortality. Around that time in the US, they were finding that 50% of those that died were of a BME origin. Now, I'll take you back quite a bit now, probably for the whole time that the NHS has been around. So we know that there have been lots of studies around ethnic health disparities. And in one study, over 400,000 individuals who were permanently registered with general practices in London, they found that BME people had a higher prevalence of type 2 diabetes compared to white individuals. And they also found that BME people developed diabetes at a younger age. There was a prevalence of hypertension, which was considerably higher amongst Black, African, and Caribbean groups. And so on and so forth. They found that coronary artery disease associated mortality was 40% higher in South Asians. And this slide by my colleague James Nasru shows you very clearly that there is obviously a huge disparity within the BME community as well. The Bangladeshis, which is right at the top of your graph, have the highest mortality or the risk from getting ill, severely ill, particularly in their latter years. The Indians are catching up in their old age, and along there are the Pakistanis and the Caribbeans, while the white British are doing rather better than all the BME groups.
Sorry to interrupt, JS. We can't see your presentation, so...
Oh, you can't?
No.
Oh, beg your pardon. I wonder what's happened.
So it's just share your screen.
I'm glad you've told me that. That wasn't very clever, was it? So let me see what's happened, because the screen was shared before. Okay, now. I seem to have got out of that screen before. Am I there now?
We can see your screen now. We can see your whole PowerPoint.
Thank you. I won't go take you back because otherwise we'll lose valuable time. And of course, now we also know that in terms of illnesses, migrants, first generation migrants don't do very well. Certainly in my field, which is psychiatry, the first generation migrants are more likely to be diagnosed with schizophrenia, 3 times more likely than white British. And amongst migrants, mood disorders are 1.5 times more likely to be diagnosed than white British. And of course, migrants' children also appear to be overrepresented. Nearly 4 times as many will be diagnosed with psychiatric disorder, schizophrenia, compared to white British. So is ethnicity a risk factor for COVID-19? Well, the earlier research data, which came out very early on in the pandemic, which started, as you're aware, in this country around about February, March, there wasn't very much conclusive evidence, but preprints and research in the gray area indicated, yes, that was most certainly the case, because ICNOG produced data which was quite compelling, which I will come to in a minute. And again, at the same time, in other countries, these disparities with BAME population were already being noted. Now, ICNOG showed that in a large population of patients, 8,699, that about a third of the patients admitted were of BME origin. And the orange bar, as you will see, represents patients with COVID. Sorry, in the general population, blue bar is patients with COVID, and in the Asian, Black, and other ethnic, they were overrepresented compared to their own numbers in the community and compared to white people. We knew already that there were a number of possible explanations for this. So possible explanations might be social, economic, health inequalities, genetic predisposition, biological or pathophysiological differences, higher burden of comorbidities such as diabetes, metabolic syndrome, and of course, what has been quite well noted in the news and in some research papers, increased prevalence of vitamin D deficiencies and lowered inflammatory responses, although NICE has actually not accepted that. Also, there were other susceptibilities amongst BME people. As we know, practicing physical distancing was a challenge. Working from home was also shown to be not so possible. They had difficulty isolating and protecting older family members or isolating those who were at risk. And also BME staff were having difficulty getting sick leave, and as we know now, having proper protective measures. Now, something in the fabric of society has been exposed by COVID-19. And we know that there are an enormous amount of economic deficiencies or disparities amongst all the BME people, from Black, African and Caribbean people, Pakistani people, Bangladeshi people. There have been a whole host of issues around economic downturn, which may in turn affect their physical and their mental health. Too many to go through now, but as I can demonstrate through this slide, there are a number of issues to do with the shutdown, the lockdown, and the fact that many are self-employed in jobs such as driving taxis and buses and that sort of thing, which were put to risk. And their women tended not to have employment, so they were more dependent on the men. And all that affects the family income and also affects their health. Now, there's also data from across the US, as I've mentioned before, and there are details coming out now that we know amongst healthcare workers too. So within the NHS, 21% of healthcare workers come from BME backgrounds, but they accounted for more than 63% of COVID-affected deaths amongst healthcare workers. And even in the US, as I've mentioned, Black people represent 13.4% of the population, but account for over 28% of deaths. Now, the story broke out in The Guardian on the 7th of April. BME groups hit harder by COVID-19 than white people. All this is important because this affects doctors indirectly or directly, of course. And at BAPIO on the same day, 7th of April, we wrote simultaneously, actually, to Chris Whitty, Simon Stevens, when the first 14 doctors to die from COVID were BME, expressing our concern about this. The NHS Confederation, a little later on the 23rd of April, sent out an alert about BME communities and health and care staff dying from environmental underlying factors, as they mentioned. And lots of stories were then coming out in the BBC and other media to say, why are BME people dying from coronavirus? Very boldly, the BJ Sykes set out an editorial, is the virus racist? Of course, the virus isn't racist. Is the NHS institutionally racist is the question that I asked with my colleague and friend Kailash Chung. And I talked with Kailash about institutional racism. Because we noted that there were a number of physical disparities already existing amongst BME people, some of which I've alluded to. Infant mortality rates higher, diabetes, hypertension, metabolic syndrome, obesity, all higher in the BME population. Access to primary care was less possible for those of a BME origin, particularly people from the Black community. There are also diagnostic disparities, certainly in mental health. We found that in Black people, schizophrenia was nearly 5 times more commonly diagnosed than in white people. And amongst Asian people, schizophrenia was diagnosed nearly 2.5 times more commonly than in white people. And in the criminal and police system, we know that Black people are overrepresented. So there was already that exposure. The ultimate sacrifice of healthcare workers, such as amongst the nurses and midwives, 71% were BME. This is an article that appeared in HSJ. First inkling, proper inkling that this was happening. 94% of doctors who died were of a BME origin. So is there racism in medicine? Well, we know that BME doctors and medical students are up to 3 times as likely as white counterparts, or their white counterparts, to pass exams. The pass rate in postgraduate medical exams is significantly lower amongst UK BME students, and the pass rate for international medical graduates is even lower at 46% than white students whose pass rate is 75%. In 2016, 94% of white GP trainees who were educated in the UK passed the CSA examination at first attempt, while only 80% of BME GP trainees educated in the UK passed the exam. So clearly something going on. And you will be aware that Bapio famously took the RCGP to a judicial review in 2014. And the judge concluded in 2016 that it was that we didn't succeed in that case, but it was a moral victory because there was something going on with the exams. And amongst UK medical graduates, 72% of BME foundation doctors applying for specialty training programs succeed on first attempt, while 81% of white doctors succeed. And this disparity has been famously noted, first of all, by Sam Averington and Niz Ismail, who continued to do pioneering work on this, showing that if they swapped names, that the white-sounding name was more likely to be called for interviews. Consultants don't do very well either. They are less likely to get jobs, they're more likely not to apply for jobs, less likely to be shortlisted, and less likely to be offered a post than white counterparts. The basic pay for BME consultants was 4.9% less than white consultants in 2017, and median basic pay for white consultants was higher than for all other ethnic groups. Of course, BME people, as I'm going to demonstrate to you, are very well represented on the GMC register. Over 1/3 of registered doctors are of BME origin. 78% of international medical graduates are of BME origin. So we have served the NHS extremely well, whilst only 13% of EU doctors are of BME origin. So the majority of BME doctors come from the Asian subcontinent. Amongst UK qualified doctors, 22% are of BME origin. These are 2nd or 3rd generation BME doctors. However, we don't do very well when it comes to regulation. Overseas qualified doctors are more complained about than locally qualified doctors, and the GMC's fitness to practice procedures, we are overrepresented right through from complaints, referrals, complaints that the GMC investigates to sanctions or warnings that are applied to BME doctors. So BME doctors from all backgrounds were being affected by the virus, and alarm bells should have been ringing. The first doctor who rang the alarm bell publicly was Dr. Abdul Chowdhury, who paid the ultimate sacrifice. He died 5 years after writing to the PM about proper PPE. And despite people from ethnic minorities having established histories of medical problems, there was an adequate protection that was being granted. Chan Nagpal himself said it is important to ascertain whether there are occupational factors that have played a part in these healthcare workers contracting the virus. We did a survey, BAPIA did a survey of BME hospital doctors' access to PPEs, and in over 1,200 of those respondents, only 22% of them said that they had adequate access to PPEs, rather similar to, I think, a survey done by the BMA. 78% had either poor or no access, and 4% were reprimanded from wearing PPEs. Also, hospital doctors from a BME origin found it very hard to social distance. We found that only 22% could fully comply with social distance guidance. We also found that comorbidities were high amongst hospital doctors. 30% of them reported that they had comorbidities. There'd be no shortage of tools, but is there a will to apply them? We've seen, I was involved in the earlier review, the NHS England review, and reports have come out that actually only 23% of trusts have implemented these risk assessment tools. There have been many of them around, the BMA COVID-19 assessment tool, All Wales COVID-19 tool, BAPIA Welsh Government assessment tool. Many hospitals, trusts have their own tools. So the impact of racism is really quite profound, whether that's in the community or whether that's in medicine. Of course, in medicine, we get it from both sides, as we're also part of the general population. I would put it to you that institutional racism is deeply embedded in society and hence in the NHS. And at a lesser level, it leads to a failure of the community to thrive. At an extreme end, it leads to death. And racism leads to unequal access to healthcare, social services, education, employment, housing, affects all tiers of our society. And it has a major impact on health as well as economy. What about impact on racism? Well, burning injustices. Black lives matter. All lives matter. All houses matter. But the black house is on fire. This is a quote I found in the American Psychiatric Association. So the NHS plan that came out very recently was like this, that every member of staff should have a risk assessment to keep them safe. Every organization needs a BME leader. Diversity should be at every level, and a bespoke health and well-being offer should be made to all BME staff and should be rolled out soon. Every part of the system will use guidance on increasing diversity and inclusion. Well, it remains to be seen. You know, I've counted there have been 14 different initiatives in the last few years. Not many of them have come to anything at all, I'm afraid. So I don't want to sound like I'm skeptic, but it remains to be seen whether there's a will to implement these. My top 5 calls are like this. Racism and discrimination affects careers and obviously affects doctors very much so. Many BME doctors were exposed to this at the front line, despite having vulnerability factors, and there should be better regard paid to risk assessment and shielding doctors who are vulnerable. PPEs must be adequate and in full supply, and those who are vulnerable should be deployed in safer areas, and the PPEs must absolutely protect those who are in the front line. Doesn't matter whether you're BME, white, or whatever your origin is, it should be adequate. You wouldn't send a fireman to douse a fire without fire equipment, just as you wouldn't send a soldier to war without ammunition. BME doctors must also be aware of their own vulnerabilities and tackle their own health issues. And the GMC also tells us that we should be doing that. And we should have better data collection. We have really been very poor at data collection despite all the pandemics we've had on ethnicity, and take responsibility for ensuring proper prospective research is conducted and lessons can be learned. Thank you. So I have a few questions that I've got here. Jess, I'm happy for you to prompt me if I lose track of any, but I've got some pre-printed questions which I'm going to read out. Okay, so one question was about risk assessments. What are the risk assessment strategies and actions required to support BME staff who are disproportionately more likely to suffer badly or die from the coronavirus? Well, I've actually discussed this in my presentation. What I cannot tell you is which risk assessment tool would I actually recommend to you. I mentioned a few tools, but even I couldn't tell you which one is appropriate. What it needs to have is every risk assessment should have BME as a risk factor, and all those health morbidities such as metabolic syndrome, vitamin D deficiencies, cardiovascular problems, respiratory problems, all of those things need to be there. There should be a stratified risk assessment, and out of that should come a dialogue. That dialogue is hugely important, and that dialogue needs to be had with a doctor who might be your lead consultant or your lead GP or your clinical director. And that is the dialogue that will actually formulate a plan with yourselves as to where you go to with that, because we know that this disproportionality cannot continue. Second question was about institutional racism. COVID has highlighted institutional racism across society. How should the NHS respond to it? Well, the NHS has just declared their 5 asks about this, which I read out. But I've also said that I have 5 asks as well, 5 calls about what we should be doing, such as proper protection, and if people are vulnerable, to put them in an area where they're not on COVID-affected wards. So that's the way the NHS should respond to it, and the NHS really needs to take seriously to it. We don't want any more reviews, we want action, is what I would say. What effects has this had on the health of non-white staff? Well, I know a lot of my white consultants and GP colleagues have been badly affected by BME doctors dying as well. It's absolutely. And as my last quote says, justice will not be served unless those who are unaffected feel as angry and upset about this as those who are affected. So this is for all of us. It's not just for BME people. How do we appropriately raise concerns about colleagues' well-being, including mental well-being? Tricky question. I guess it's up to us as doctors to be aware of our own physical and mental health. The GMC lays this out for us. But also, if we are concerned about somebody, I think it's very appropriate to either raise it ourselves or to find a person who might be the most appropriate person to do that. That could be a friend of that doctor. That could be a senior doctor, somebody who's in a line of responsibility for that person. It could be a supervisor for a trainee. I think it's incumbent on us to try and do something about it. How do we deal, this is a difficult one, having been a medical director. How can we deal with difficult passive-aggressive line managers when it comes to the health and well-being of high-risk BME employees? Well, we know this is a very serious issue and serious risk, because BME people died and will die on the front line unless action is taken. I guess if your informal soundings haven't given you the right result, you have to put things in writing. I mean, I think it's better to do it openly in a transparent way, but make sure that you sound some of your colleagues out, make sure that you've got the right take on this, try and be as objective as you can. But at the end of the day, because this is such a serious issue, something will need to be done. And that might mean making it formal. Any special short or long-term advice for shielding doctors and or BME colleagues. I think I've already mentioned that, and I certainly would say that shielding doctors who are at high risk is particularly important, and the NHS must take it seriously. And of course, as you will see, there are likely to be cases, legal precedent on this, because this is such a matter of such importance that trusts are beginning to take this serious. I know some trusts that have taken this extremely seriously. I dare not name them, but I would love to, but I think they should be an example, and people need to say it out that this needs to be done. And trust should be an example to each other. Now, I can't see you, I'm afraid I can't go into the other.
JS,
Yes.
I can
Yes,
read
yes.
some of the questions that have come through.
Please do.
Someone sent through a question, so I really fail to understand, and I'm very sad and this happens, difference in salary for the same role between BAME and non-BAME. Wouldn't the salary in a public job be predetermined for anybody in that role?
Well, absolutely. It beats us, doesn't it? But you know, there are incentives within the salary scales, an optional point here or there, discretionary point here or there. There are levels, there are inducements such as waiting list initiatives. There's a whole system which is, I'm afraid, prone to fairness. And that lack of transparency is what has caused that differential in pay.
Okay, great, thank you. Ranjit said, is there any data on the relation between COVID and the number of hours worked, locum versus substantive job, less than 4 members versus more than 4 members at home?
So the whole problem, Ranjit, with this has been the lack of data, to be truthful, because ethnicity wasn't recorded in the NHS. There have been calls now for that to be absolutely embedded in this, including in death certificates. And that sort of data about is very obviously, you need consent of individuals. There hasn't been that system framework to have that sort of thing. What we do know is that a lot of these BME people were right in the front line. That much is absolutely true. And many of them did not have proper PPE despite asking for it. And we have a number of reports of people, BME people particularly, being reprimanded from asking for PPE. So I'm afraid that data isn't there, but needs to be collected urgently. Locums, I would imagine, would have been particularly in a difficult position, because if they don't do the job that they're asked to do, they're not given a contract. So I think it'll be good to see all of that data played out. And of course, BME doctors will be overrepresented in locum agencies as well.
We have a few other questions, but I'm conscious of time and this session is going to end in 5 seconds. So we might just come back.
People email them to Jess, to me, or to yourselves, and I will answer every question.
Yeah, okay. Great.
Thank you very much, everyone. Thank you.
Thank you.
Thank you, Jess.
Thanks, JS.
Bye.